Hello, good morning. Welcome to St. Louis and my office. I believe, I might be wrong, but I believe that this is the first time the VESS has been held here. The next presentation we have is Procedure Reimbursement, Inflation, and the Declining Buying Power of the Vascular Surgeon 2011 to 2019. This will be presented by Jack Haglin for our colleagues from Mayo Clinic Scottsdale and Mayo Clinic Phoenix. Take it away, Jack.
Hello, my name is Jack Haglin, and I'm a fourth-year medical student at the Mayo Clinic, and I'd like to sincerely thank the VESS for allowing us to present our work virtually today. There aren't any relevant disclosures related to this presentation, and full author disclosures can be found in the program. So getting started with an introduction and kind of background of this project, it's important to understand that Medicare currently reimburses physician services via a structured, annually updated fee schedule. And to start, it's important to really define the underlying structure regarding Medicare reimbursement to physicians. So Medicare currently reimburses physician services via a structured system on set national relative values for each procedure performed by surgeons and physicians. Each procedure is assigned a current procedural terminology or CPT code, which is then tethered to a specific and predetermined reimbursement amount based on the resources required for that individual procedure. And this payment then given to physicians is based upon relative value units or RVUs, which are a summation of value units allocated for work, expense, and malpractice given to each procedure. And this summed RVU is then multiplied by a geographic modifier, and this value is then again multiplied by a standardized conversion factor to convert the RVU value units to a monetary reimbursement rate, which is then fed forward to the physicians. As policy surrounding healthcare spending continues to evolve, it is important to evaluate these trends in Medicare reimbursement in vascular surgery throughout the last decade. So given the fact that Medicare comprises a large and ever-growing portion of physician reimbursement in the United States, as well as the flux we currently find ourselves in regarding healthcare policy in this country, the purpose of this study was to evaluate trends in Medicare reimbursement rates to vascular surgeons for commonly performed procedures within vascular surgery from year 2011 to 2019. And getting into our methodology, so for this analysis, the 20 vascular procedures most commonly billed to Medicare were identified using the 2019 Physician Supplier Procedure Summary file from CMS. And for each procedure within this, the physician fee schedule lookup from the CMS was queried. And this database provides Medicare reimbursement fees for each procedure for each year since the year 2000. And pricing information for each procedure was then collected for all Medicare administrative contractor options and modifiers, and each geographic iteration of the reimbursement was averaged to reflect a comprehensive reimbursement for each procedure for each year in the study. The raw total change in reimbursement rate was calculated for each procedure and compared to the change in Consumer Pricing Index, or CPI, throughout the study period. And the data was also adjusted for inflation utilizing the CPI for each year throughout the study. This adjusted rate represents the true buying power of the vascular surgeon receiving payment for such procedures in each year. This adjusted data was utilized to report adjusted to total percent changes across the study. And then sub-analysis, an identical analysis, was repeated for the 20 most common procedures in orthopedic surgery, general surgery, and neurosurgery. And then ANOVA analysis was utilized to compare mean reimbursement across specialties and compare that to our findings in vascular surgery. So moving into our results, when adjusting for inflation to 2019 dollars, the average reimbursement across all included vascular procedures declined by 13.6% between 2011 and 2019. And this data can be seen in the table. These findings varied by procedure, with the greatest mean decrease observed with endovenous ablation therapy of incompetent vein of an extremity at negative 30.9%. And then when assessed across procedure type, venous procedures experienced the largest average decrease of negative 22.6%, followed by endovascular procedures at negative 14.2% on average. And finally, open procedures decreased the least on average with a mean of negative 9.9% throughout the study when adjusted for inflation. This was statistically significant difference across procedure types. So continuing the results with that sub-analysis across specialty types, when the analysis was repeated across other specialties, vascular surgery had the largest mean decrease at negative 13.6%. And this was compared to negative 8.6% in orthopedic surgery, negative 8.5% in general surgery, and negative 6.2% in neurosurgery. And these differences were statistically significant across specialties via ANOVA analysis, with a p-value of 0.004. So moving on to the discussion and implication of these findings. The implications of these findings are widespread and important. Currently, there are several strategies and payment models being discussed, proposed, and tested to potentially stabilize reimbursement within vascular surgery. And despite interest in these sort of alternative payment models, there's been notable difficulty properly risk adjusting patients under these potential models, as well as difficulty defining standardized and attainable outcome measures within these models. And so as such, despite these discussions of these new payment models, the process of identifying a real gold standard model of reimbursement in vascular surgery is still in its infancy at this time. However, garnering a comprehensive understanding of reimbursement trends like those described in this study will be an important undertaking when defining future policy, and we feel this data will be important for that. Further, in 2015, Congress passed the Medicare Access and CHIP Reauthorization Act, otherwise known as MACRA. And under this relatively new ruling, MACRA avoids scheduled cuts to reimbursement and instead provided an annual increase in Medicare reimbursement each year through 2020. And given its recent adoption, as well as its incentivization of some other alternative payment models for physicians, the effects of MACRA remain relatively undefined. However, it may have had a brief stabilizing effect on reimbursement rates. It's also, this is very important in this current day and age because it's particularly relevant given the recently adopted physician fee schedule for year 2021, recently released by CMS. This took effect on the first of the year, and vascular surgery is actually particularly affected, as I'm sure many of you know, and there's an average cut of 7% decrease scheduled for services billed to Medicare in 2021 related to vascular surgery, which is one of the largest cuts across any specialty in medicine. So ongoing discussions regarding emergency policy, which would delay this cut, are currently being discussed and evaluated in Congress. These undertakings have been publicly supported across medicine by the AMA and the likes, and then particularly within vascular surgery, the SVS has publicly supported this legislation and is hoping it'll pass. However, it remains to be seen at this time of the recording whether this legislation will be signed into law, but it certainly is an important undertaking to be aware of, and I feel that this data is going to be important in the future. Finally, access is an ever important discussion of today, so fair and adequate reimbursement is necessary to ensure continued access to quality care in vascular surgery, and future payment models will need to be mindful of this data in order to assure access to our patients. And this is especially true when considering the differences in reimbursement across specialties that we described in this study. Thank you so much.
Awesome. Great talk. While we're waiting for questions, I'll remind the audience to send any questions via the chat function. But I'll start off with some questions here. Endovascular stuff is kind of newer technologies, and I'm just curious, you compared vascular surgery to other fields like orthopedic surgery, general surgery, who probably don't have a lot of these newer technologies. Do you think maybe we just overvalued the endovascular techniques and we're just coming to the norm of value for those newer techniques, and when comparing to these other fields that don't have a lot of newer techniques using newer technologies, the comparison isn't fair?
Yeah, I think that's a great point that you bring up, and one that we were talking about too, and is in our discussion in the upcoming manuscript. And so it is a little bit unfair in that way that you mentioned to compare it to different specialties that have more established procedures. However, I think it's still important to note that this is how it's changing. Another, important related concept to this is that the way that these values or these procedures are being valued by the CMS, I'm sure many of you know or have heard of the RUC committee, or the Relative Value Update Committee, and it remains to be said that the RUC is currently comprised of 25 different specialties across medicine, including orthopedics, neurosurgery, general surgery, etc. And there isn't a primary seat on that committee from vascular surgery. So we don't quite have the representation at the table within the CMS that other specialties have as well. And that could also be playing a role in these findings.
Awesome. A couple of questions from the crowd. Michael Amendola says, thanks for your interesting and important work. I have a question. Have you looked at your local data within your healthcare system in a similar way?
We haven't, but I think it's really important, and that's the next step. So this analysis was more of a primer and just uses as an example. All we did was looked at physician fee schedule. So this wasn't even representative of true payments, although payments to Medicare are tethered to this fee schedule. But there's obvious geographical variation, and that's the next step that we're looking at, is how these differ from state to state and locality to locality. And then, of course, it would be great to compare these physician payments to hospital reimbursement as well. And so that's something that we're hoping to look at next. And I think that's a great idea for future study.
Another question from Dr. Stern. And just imagine if this had been cut again, yet more evidence of the persistent undervaluing of our specialty. How do we fix this? Should we have more government advocacy via the SVS PAC or some other way? Great talk and topic. Do you have any comments to that?
Thank you. Yeah, that's the question of today, I think, is how do we go about changing this trend? And I think one thing would be increasing representation from vascular surgery. So we do have lobbying on our behalf, but just increasing that representation is going to be important. And then looking at how physicians can still be incentivized with some of the new upcoming alternative payment models being discussed is going to be extremely important as well. For example, there's been some talks of carotid endarterectomy being put into a bundled payment, and we just want to make sure that these trends of decreasing reimbursement aren't also being exacerbated in a future bundle. There is some good news with recent policy since we recorded this talk. In the stimulus package that was recently passed, there is actually a 3.75% increase to all Medicare physician payments across all of medicine for 2021 related to COVID-19. And so at least there's a temporary reprieve, but that 7% decrease to vascular surgery is still implemented as of the first of this year. So it's an important ongoing topic of discussion.
Then one more question is an interesting question, actually, from Chris Chow says, interesting study. Thank you. Did you look to see the differences between each year and see what the legislation was each year? And then more importantly, did you look at SVS PAC and other contributing entities as far as if we helped make any changes with legislation during those time periods?
Yeah, that's a great question. And so just primary analysis across just these 20 procedures, we didn't really notice anything significant based on ongoing legislation or ongoing policy advocacy efforts. However, I think what we'll do as we are preparing our next study is looking at a larger cohort and looking essentially at all of vascular surgery and then comparing it to those big milestones. So this study was limited to just 2011 to 2019, but when we look from the year 2000 on, we do see some tied to legislation. There was a massive cut in 2002, and then there was a large decrease from 2011 to 2015 when some of those endovenous procedures came about. And then in 2015 with macro, there was a slight stabilization, and then now we're seeing another decrease. So I think it's really important to see how this is relating to policy, and will educate us moving forward to be most informed to protect the vascular surgeon and care the patients in the future.
Great job. I know you're a medical student and you don't know a lot of things, but it seems like you know a lot of things about this. The one thing you don't know a lot about is you're not supposed to wear a tie at the VESS. So next time, don't wear a tie.
I certainly do not know a lot of things, but I'm always trying to learn. So thank you.
All right, we'll move on to the next presentation.